Okay, for chapter 12, we're going to be looking at the process of birth together. Okay, so this is a PowerPoint. This one's a little bit longer, but we'll be reviewing a lot of the physiological processes in the birth process. Reproductive system, characteristics of contractions. So contractions are essentially kind of the flexion and release and relaxation of a muscle. They're coordinated. Their frequency can be several intervals. For some patients, they might contract in the beginning of their labor every 10 to 20 minutes, and then as labor progresses, it might be every 2 to 3 minutes. Frequency is noted from the beginning of one contraction to the beginning of the next. Duration. So not only are we looking at how frequently contractions are occurring, but we're also looking at how long they're lasting. So the beginning of one uterine contraction to the end of the same contraction. We're also measuring their intensity. Contractions come in 3 speeds: mild, moderate, and strong. These are involuntary, so nothing that the patient is doing is causing these contractions to occur, and they're intermittent, okay, in a spontaneous labor situation. Reproductive system continued with the contraction cycle. It is incremental, so there is going to be a period of increasing strength. So, hence, contractions starting out at that mild point, maybe a little further apart from each other, perhaps every 10 to 20 minutes. And then as labor progresses, they're going to get not only stronger, but closer in interval as well. The period during which the contraction is the most intense is the acne, or the nadir, the top of the contraction. As that period wears away, the uterus itself starts to relax, and you have periods of decreasing intensity, so the relaxation. We can see that example in the visualization on slide 5 of 50 here. So the contraction kind of builds, it comes to a peak, it's the strongest part of the contraction, and then it relaxes. In the next slide, slide 6 of 50, we can see the upper 2/3 of the uterus contracts, and that helps to kind of create pressure on the cervix and helps to push the baby down. Creating that pressure on top of the cervix also helps to thin out and efface the cervix, if you will. So thinning out is the effacement, is the technical term for thinning out of the cervix. And it also helps to promote dilation. The lower 1/3 of the uterus remains kind of less active, and the top part of the uterus there, we can see those arrows coming down, is the most active part of the uterus. Okay. Cervical changes. So I said before, I talked a little bit about effacement for about a second. So the cervix also goes through changes during labor. The cervix has to begin to have a process of effacement, which is the thinning out and shortening of the cervix. And the cervix kind of starts out pre-labor, kind of like a cone, pointed a little bit towards mom's rectum. So that cone needs to come forward to the center of the entrance of the vagina, also needs to thin out, and it needs to start to dilate or open. Effacement and dilation occur concurrently during labor, but at different rates. For example, first-time moms or women who are nullips will thin out their cervix before they start to dilate a little bit more, versus multips or multiparous women who've had multiple babies and have had labor before. They will usually dilate and thin out their cervix at similar rates. Okay, in our next slide, we can see the nulliparous woman, a woman who's not completed a pregnancy, at least at 20 weeks of gestation. So it's just a term we use to describe those types of women. Completes most cervical effacement early in the process of cervical dilation. So that example I had just given you before. And parous women are women who have had birth and pregnancy at least at 20 weeks gestation. So the cervix is usually thicker during that point in labor, and those women tend to kind of move a little faster in the work of labor. And we can see that side-by-side comparison in slide 9 of 50, the primigravida versus the multigravida there. The maternal cardiovascular system. Blood flow to the placenta decreases during a contraction. So we have a little bit of compromise there in blood flow, and that passive diffusion the placenta experiences. The muscle fibers of the uterus constrict around the maternal arteries, which supply the blood supply to the placenta. And there is a relative increase in the woman's blood volume. So as she is starting to contract, that blood volume increases. This is a temporary change, and her blood pressure might be impacted by this change. So it's important that when we're assessing vital signs on our patients, we do not assess vital signs during a contraction. Another piece to that that's also important to consider is the pain factor. If a woman's uncomfortable, of course, those changes are going to be reflected in her vital signs as well. Supine hypotension may occur during labor if the woman lies on her back completely, and that is because of the uterus itself kind of occluding the superior vena cava and putting the pressure on those major vessels there. The woman should be encouraged to rest in positions other than supine to promote blood return to the heart. Women can even feel a little lightheaded or dizzy if they are flat on their back. Maternal respiratory system. Women who are pregnant have an increased rate of depth and respirations. It makes sense, they've increased their cardiovascular volume, they've increased their weight, they have a larger organ, and they have a fetus to accommodate for, so they have increased rate of depth and respirations. These patients might also be at risk for hyperventilation. It may occur with rapid and deep breathing. Respiratory alkalosis occurs as a woman exhales too much carbon dioxide, making her feel kind of lightheaded and tingly in her hands and feet, maybe even some numbness. So it's important as a nurse or as a labor nurse to help a mother kind of slow her breathing, encourage that big deep breathing. It says that they can kind of breathe into a paper bag or cupped hands, if any of those items are on hand, but really encouraging that big deep inhale and a nice and slow exhale so that we can restore those normal blood levels of carbon dioxide and relieve any type of those symptoms that a mother might have. The maternal gastrointestinal system is affected during labor as well. Women in pregnancy have decreased gastric motility. So most women are not hungry but are thirsty and have dry mouths. And that's just because of the motility kind of being decreased. It takes a lot longer to move that food kind of further down into the digestive tract. Ice chips are commonly provided in labor, and most labor and delivery places will have moms on a clear liquid diet to prevent any type of respiratory aspiration from any food particles brought in. Small amounts of clear liquids might also be allowed, like I had reported there. Maternal urinary system. So as labor continues to progress and we think about the anatomy of where the uterus is, where that fetal head is, and where the maternal bladder is, moms might have a reduced sensation of a full bladder, especially as that fetal head begins to kind of compress the bladder itself. Full bladder can inhibit fetal descent and occupy space in the pelvis. So moms are encouraged to empty their bladder at least once per hour to promote more kind of space in the pelvis there. When we talk about the maternal hepatic system, we're going to talk about the amount of blood loss usually experienced during a vaginal delivery. On average, women can lose up to 500 mLs or 500 cc's of blood loss during a vaginal delivery. And during a C-section, we almost double that, 800 to about 1,000 mLs or cc's of blood loss during a C-section. And let's remember that moms increase their cardiovascular volume during pregnancy about 10 to 15% to accommodate for some of this blood loss as well. Levels of several clotting factors, especially fibrinogen, are elevated during pregnancy and continue to be higher during labor, and that's to help protect moms who might be at risk for hemorrhage. It increases their risk for thrombus events, though, during pregnancy, not only because of the increased blood volume, but also of the increased fibrinogen levels. Those are some of our clotting factors we see, so it's important that we consider some interventions to help decrease the risk of deep vein events, deep vein clot events in moms. So for example, promoting the use of SCDs or the sequential stockings to help moms prevent a risk of a DVT or clot after a C-section. Physiological events of the birth process, including the fetal response. So we already talked a little bit about that placental circulation, how there is a little bit of a decrease of blood flow in the placenta during a contraction. The placenta, however, is still responsible for the exchange of oxygen, nutrients, and waste products. Most placental exchanges occur during the interval between contractions, like I said, because of the decreased blood flow during an actual contraction itself. Cardiovascular systems respond to stress, and we talk a little bit about during class last week how the fetal heart exhibits stress or how it communicates to us during the labor and birth process. The fetal heart rate ranges from about 110 beats to 160 beats per minute as the average heart rate. Pulmonary system. Lungs produce fluid to allow normal development of the airway. So it's important to assess the pulmonary system or that oxygenation status of the fetus. And we saw that in the variability of fetal heart tracings. Components of the birth process. When we talk about components of the birth process, we're going to talk about 4 major factors that interact during normal childbirth. We're going to use the 4 P's to describe that. The powers, meaning the maternal power and effort, the passageway, meaning the birth canal or the vagina, the passenger, we're going to talk about the fetus, and the psyche or the maternal outlook and experience on labor and delivery. And we're going to talk about the interrelationship of these components. Let's talk about the powers first, the maternal powers. So when we talk about the maternal powers, we're talking specifically about uterine contractions, which are the primary force that moves the fetus through the maternal pelvis, as well as maternal pushing efforts. So in order for mom to have or exhibit her pushing efforts, she needs to be 10 centimeters dilated and 100% effaced. Women feel an urge to push and they bear down with contractions, kind of using the power of the contraction as well, to help the fetus descend through the vagina and put pressure on the rectum, especially as she's bearing down. Other components of the birth process include the passageway. So we talk about the bony pelvis, and in class we got to see an example of a pelvis, and we talked a little bit about a true pelvis versus a false pelvis. So usually more important to the outcome of labor than the soft tissues, the bony pelvis, the bones and the joints do not readily yield forces to the power of labor. So the pelvic brim divides the bony pelvis, and we can see better pictures of this in the following slide, and the false pelvis above the linea terminalis and the true pelvis below the linea terminalis. And we saw that in our model as well. The true pelvis is what is most important in childbirth, and we talk about the stations as well and using those ischial spines as landmark. The inlet of the pelvis, the mid-pelvis, and the outlet. So those would be the most significant during labor. And in slide 19, we can see the inlet over here. We can see the mid-pelvis, pretty close to those ischial spines right there. We can see that outlet. So there's the most significant for labor and birth. Components of the birth process. The passenger. The passenger is the fetus, the membranes, the placenta, anything that is a product of conception, part of the conception that has to make its exit out after the delivery. Several fetal anatomic and positional variables influence the course of labor. You know, if the baby is in a position where they're facing up at the ceiling, the occiput, or the top part of their head, the occipital bones, are posterior in the pelvis, that's going to be a position that's more challenging for labor and birth. So that really influences the labor process itself. Other components of the passenger include the fetal head. Cephalic presentation, we also call that vertex presentation. So in order for vaginal delivery, we have to have a baby head first before we deliver any other part of the baby typically, especially in first-time moms. We use the sutures of the frontal lobe bones in the forehead as landmarks to assess fetal position. 2 parietal bones at the crown of the head and the occipital bone at the back of the head. The fontanelles are wider spaces at the intersections of the sutures connecting the skull bones, and that's what helps the fetal bones kind of overlay on each other and allow for their journey through the passageway. Anterior fontanelle is more of a diamond shape, while the posterior fontanelle is more of a triangle shape, and the fetal head kind of diameters, which allow for that head to kind of mold and shape and take on that kind of cone shape appearance to allow them to come through the passageway for a vaginal delivery. Okay. Components of the birth process, variations in the passenger. So let's talk a minute about fetal lie. So the orientation of the long axis of the fetus to the long axis of the woman. More than 99% of pregnancies, the lie is longitudinal and parallel to the long axis of the woman, meaning that the baby is in a vertex presentation or head down presentation. These babies can also kind of be little acrobats and turn around and reposition themselves. So we can see an example of a transverse lie in slide 25. Components of the birth process, variations in the passenger. Again, the altitude, relationship of the fetal body parts to one another, flexion or extension. So let's for a moment talk about those occipital bones, the back of the baby head bones, as our landmarks. So when we're assessing fetal position and we're feeling those occipital bones first, as we would likely in photo A, that baby has a they're going to face the floor when they turn around, and we'd feel their flexion, their chin coming down to their chest in this position, an ideal position for birth. In photo B, this is the extension of the fetal head, so this would make labor and birth more challenging. So that occipital part of the bone, using that as the landmark, would be in a posterior presentation, more challenging for this baby to kind of come through the passageway. Presentation, fetal part that first enters the pelvis. So that would be what area of that fetal head is entering the pelvis first. Is this a fetal head that is in full extension? Is this a flexed baby? When we talk about position, vertex meaning head down. Military position, so they'd be presenting their chin a little bit more. Brow, they'd be presenting their kind of forehead first, and their face presentation, so that full face coming through the pelvis. Breech presentation, so their baby bottom would be presenting first. A frank breech would be a full baby bottom there, while a footling breech would be a bottom with one foot extended into the lower part of the pelvis. Or a shoulder presentation, where there's no fetal head, and it's more the shoulder presenting into the pelvis. It's not a position for birth vaginally. We can see some examples of those presentations in those photos there. Components of the birth process, variations in the passenger. So let's continue on with that. So position, location of the fixed reference point on the presenting part in relation to the four quadrants of the maternal pelvis. So when we look at slide 32, we'll be able to differentiate our quadrants, as that photo is kind of made a little square itself within the pelvis. So when we're assessing fetal position, we would be able to differentiate, is the fetus tilted a little to the left? Is it tilted to the right? Is it posterior, meaning closer to mom's sacrum, or is it anterior, closer to the top part of the pelvis itself? Important terms used to describe the position of the baby when we're assessing their journey through the pelvis. And in slide 33, we can see examples of what the fetus looks like as it's coming through the pelvis in relation to how they describe it using the terms there. Let's talk about one of my favorite P's here, the components of the birth process, the psyche. So really influencing how the maternal experience can impact labor and birth. Anxiety, cultural expectations, birth is an experience, whether the mom is supported or not, does she have people in there that are helpful, and the impact of technology. So those are really important components to consider during a mom's labor and delivery. Components of the birth process, interrelationship. The 4 P's are actually all interrelated as a whole. They kind of build on each other. The nurse acts as an advocate for the laboring woman and her support person to increase their sense of control and mastery of labor, which often reduces anxiety and fear and helps them to achieve their desired birth. So really considering the RN role as the facilitator for labor and birth, advocate for a good labor and birth experience, helping to influence that psyche. Normal labor, exact cause is unknown. There's a ton of theories of onset. Some theories talk about that the fetus releases hormones and the mom releases hormones, but really labor is spontaneous. Factors that appear to have a role in starting to induce labor include a progesterone withdrawal, release of prostaglandins, increased secretion of natural oxytocin in the brain, increased oxytocin receptors in the uterus, increased stretching and pressure of the uterus and cervix. So those are all likely factors that influence labor and birth, but really at the end of the day, labor and birth is a spontaneous event. Normal labor. So some pre-labor signs that a patient could experience include those Braxton Hicks contractions or the kind of abdominal tightening. Lightening is when the fetus kind of drops lower into the pelvis. This can sometimes improve maternal respiratory effort as the fetus is not creating as much pressure on the diaphragm. Increased vaginal mucus and secretions can be exhibited towards the end of pregnancy and considered a sign of pre-labor. Cervical changes as well. The cervix becomes softer. There's possible dilation. Maybe the cervix is open a small amount. There's some bloody show, so the discharge of some vaginal bleeding mixed with cervical mucosa. And there sometimes could be a little bit of a burst of energy for these moms, as well as a little bit of weight loss experienced through vomiting and diarrhea. And that can just be our body's way of kind of discharging or getting rid of the items it no longer deems necessary for the work of labor. True labor versus the false labor. So true labor would be increased contractions. We know that they're rhythmic, kind of like the waves in the ocean, right? They go forward, they come back. They go forward, they come back. They produce increased discomfort, so they build on each other. They start mild, they become more moderate, and then they become strong. Cervical changes, progressive effacement, and dilation are the most important components of true labor. False labor, contractions are inconsistent. They might have 4 contractions in an hour and then none for the next couple of hours. Discomfort is more annoying than truly painful, so it's more of a discomfort again than something that is described as very painful. And most importantly, the cervix does not change. True labor is defined by cervical change. Labor mechanisms here. So the cardinal movements of labor. The fetal head descends, it engages into the pelvis, it flexes by bringing its chin closer to its chest. They have an internal rotation, so they might kind of turn to face mom's back when they're coming into a side position. They extend their head underneath that pubic symphysis. They externally rotate during delivery, and they have a complete expulsion. Normal labor mechanisms continued, so we can see the fetal head descent. They're measured using the stations, where the ischial spines are the 0 station, and engagement is the fetal head presenting to that 0 station, the true pelvis, if you will. We talked a little bit about the descent, engagement, and flexion. And we can see a little bit more of that visualization. There's that fetal head descent. It engages into the pelvis. That chin comes further tucked into the chest, and they have an internal rotation through the pelvis. Okay, we can see that in that visual of slide D and slide E and slide 43. And then in our normal labor mechanism continued, or slide 44 of 50, we can see those cardinal movements of that fetal head coming through the passageway as they continue to rotate there. And you can see those on the right-hand side of the visualization. The baby starts to turn and restitute as it's being delivered. Normal labor stages. The first stage of labor, we call that the latent phase. So that's going from 0 to 3 centimeters. In this stage of labor might not be well established. Contractions might come and go. There's a lot of variability in early first stage labor there, that latent phase. Active phase. Active phase starts at about 4 centimeters. And labor becomes more established. Contractions are definitely more rhythmic. They become stronger, so moms can continue to efface and dilate their cervix. Transition is defined at 8 to 10 centimeters, typically the shortest part of labor, but the most challenging part of labor, those final centimeters to be dilated. The second stage of labor is defined as the maternal effort and pushing. The third stage of labor is the delivery of the placenta, and the fourth stage of labor is the first several hours post-delivery, where moms are most critical, and so are babies. So we want to assess their bleeding status, we want to assess their pain, we want to assess the fetal transition to extrauterine life. So it's important to consider those factors after delivery. In slide 48, we can see a little layout of stage 1, 0 to 3 centimeters, that latent phase or the early stage of labor, 4 to 7 centimeters, the active phase, 8 to 10, transition. We see again full dilation in stage 2, delivery of the baby. Stage 3, the delivery of the placenta, usually happens about 5 to 30 minutes after the delivery of the fetus. And then the final stage, the assessment of mom in the immediate postpartum period. Okay. And then our last slide, which occurrence is associated with cervical dilation and effacement? Bloody show, false labor, lightning, or bladder distension?